shirt today. Little pocket. Oh, we got little pocket buddies. Pocket pals. And can I put some in your pocket? What? Dude, you should, it's easy to hug every time. If you give me a half a point off again, we'll just put beans in your pocket.
You know what he reminds me of? Tigger. You know? You're Tigger.
So bouncy.
Bouncy. Bouncy and happy.
He's gonna come in with like face paint next week now.
Because it is the spring. Oh my gosh.
Oh my gosh, okay. There are a couple things I want to remind everybody of. Please take a look at your syllabus and remember that game day is March 4th. So if you remember what game day is, your group, or if you want to combine groups, that's fine if you feel your group is small, must create a game from the laboratory knowledge base of brain, okay? So we've had Brain Monopoly, we've had Brain Pictionary. So the goal is your group creates the game, and then we will invite the public, whoever I can grab in the hallway, to come down and play your games. Your games will be judged and graded. It is a 20-point activity. So if you'd like to get an A and get all 20 points, work well. So in the game, I will ask you what each member of your team had to contribute. So what I'm trying to avoid is that one person who never showed up for the meetings and just didn't do anything, didn't cut any paper, didn't draw anything, didn't do the research, didn't make the question. I'll suss you out, and then you won't get your 20 points, okay? So we try to be very equitable in terms of making these games. Any questions about game day? Okay. Any kind of fun, Milton Bradley, Procter Gamble, whatever, Parker Brother kind of thing, you know, make up one that doesn't exist, that's fine. The winner of the game day, I put your games up in my office. It sits there for the year for everybody to drool on and be envious that they didn't make such a game. Owen, challenge,
We're
drop.
winning.
Okay. In addition, Kahoot Day is shortly after that, is the 18th. So those are 5 free points. 5 free points. So you should put them in the Dropbox. It should be 1 Kahoot question per lab. By that point, we should have had done 5 labs. If you know how to play Kahoot, Kahoot has a limit of characters. So if you give me a paragraph of a 57-year-old blah blah, and it's like this long, I'm gonna have to retype it, and then I'll get mad, and then I might not like your question. You see how this goes, right? So don't piss off the professor, and make it's a 4 multiple choice, or it's a true false, and it has like 160 characters. So be brief, so I don't have to reinterpret your question. Okay, so those are just 2 announcements. They're in your handout. My 2 PhD students, no game for you. You get to have a different kind of torture. Yes?
So the points, is it like a point back per point that you didn't get on the test, or?
No, it's just 5 points added to your final total. So yes, it's like, it could be 5 points on a test, but it's for the whole semester, so it's not per. So your grade is about, I think it's 220 points total.
Oh, okay.
Yeah, so it's 5 points towards the final total. So you want to look at it, add 5 points to your exam score. There's your 5 points. That's if you don't give me a kind of crappy question like, what's that blob on top of your shoulder? Then that's not going to get you a point. I'm just going to toss that, right? Use the language in your lab handout. Your practical exam in here, if you had photographic memory and memorized every word in that 100-page packet for the lab, you would be able to answer the question, because I'm literally pulling the sentences out verbatim out of the lab handout. No other information, okay? So use that strategy for the game, because if you do that, you start to really familiarize yourself with the language, and then all of a sudden you'll recognize the same sentences in the exam. Make sense? Okay. Okay, I do appreciate and thank everyone for your willingness to take this 2-hour lecture period. It does help me a lot and makes me make sure I keep you guys on schedule because we have such a tight curriculum that I don't want you to get behind in this class. So this is a review of what we've done so far in cranial nerves. 1, 2, 3, olfaction, vision, ocular motor. Ocular motor got a little complex. We've got both muscle and parasympathetic and one eyelid. The parasympathetic contributes to 2 kinds of reflexes. Now, the first one is a reflex that can happen without consciousness. You're in a coma, the doctor can lift your eyelid and still shine light in there. It'll still work. However, the accommodation reflex does require you to be conscious and willing to do it. Like you have to decide, I am going to look at this thing up close in order for all the sequences to fall into place. Obviously, if you refuse to do it and stare off into space, you can waggle anything in front of someone's face really close. They won't show the accommodation reflex, right? This is a voluntary, purposeful movement. It's what's reflexive is all the things that happen via the ocular motor that have to occur in order for the visual process to function, okay? And then the trochlear, cranial nerve 4, has one muscle, the superior oblique, and that's where we left off. Okay, so we're going to do the trigeminal. Trigeminal is a very big nerve, or a nerve in terms of function as well as size, so this is going to take a little bit. Now, the trigeminal's main function is somatic sensory. So this is one of the biggest sensory cranial nerves you have. And what kind of sensory nerve or information it conducts is touch, pain, temperature, vibration, proprioception, that goes along with touch, proprioception, for the face, mouth, tongue, your nasal sinuses, and meninges. So it covers a lot of territory, okay? And so for those who are pre-deaf, this is the cranial nerve you are most concerned with. This is the one you want to kind of shut down in order to conduct any dental work. Okay. Now, there are 3 sensory fields, so 3 afferents. Okay. So 3 afferent fields that go through the trigeminal as a cable and end up in 4 destinations. This is what makes this cranial nerve a little complicated. Okay, so remember, afferent is information coming into a location versus an efferent, which is the other way around. Okay, and so we have 4 destinations. They are the trigeminal main sensory nucleus, okay, the spinal trigeminal. Sorry, I'm going to slow down and have better penmanship. Okay, spinal trigeminal nucleus, the mesencephalic nucleus of the trigeminal. So trigeminal you'll often see with the Roman numeral V, the 5. And then something different is the trigeminal motor. So this is one of those mixed neurons that does both sensory and motor. Now the 3 afferent fields come from 3 big divisions of the face. So these are the divisions. They're the ophthalmic, the maxillary, and the mandibular. So you can kind of see their territories kind of dividing the face roughly into thirds. Okay? So the trigeminal will, for all those 4 areas, the main sensory, the spinal, trigeminal, the mesencephalic, and the motor, they all kind of contribute to all 3. So it's not like one of these fields only goes to one of the four. So they are distributed relatively evenly, except for the motor, because you don't have motor everywhere. Okay? So one of the things to keep in mind, which we'll hammer more when we get to the spinal cord, is that all sensory neurons have their cell bodies outside of the CNS. Okay? So in the CNS, when we have a group of neurons, we call that a nucleus or a nuclei. But when the group of neurons are outside the CNS, we call them a ganglion, so that you kind of know, oh, we're not part of the brain spinal cord. So in this case, our three afferent fields, which are covering those areas of the face, they send their information via the trigeminal ganglion, which means the cell body lives in a cluster just outside the brain, and then sends their dendritic information to the three different areas, and then sends their axonal information to one of the four targets. Okay? So that's the basic organization. We'll see that again in this diagram. Okay. I know it's small, but here's our trigeminal ganglion, V ganglion. Okay? So just look at the green. This will come later. This is sensory information coming from the rest of your body. So just to let you know, your face sensory information eventually joins all that other stuff coming from below in your body. So this is neuron number 1. Sensory information is carried in a 3-neuron relay. Okay? So neuron number 1 is our trigeminal ganglion. That's the cell body outside the CNS in its own ganglion. So this is coming from those ophthalmic, maxillary, mandibular sections from your face. For the main sensory, so we're going to take the first one. We're going to take each of the 4 separately on different slides. Okay? So this is the first one, the main sensory. The trigeminal main sensory, it's primarily the discriminative touch. So this is fine touch, we'll call it fine touch, vibration, and proprioception. What's missing is pain and temperature. Okay? So this is discriminative touch. These are heavily myelinated neurons, and they are large diameter. This is important, and it kind of helps you to remember. Heavily myelinated means a neuron can conduct an action potential very, very quickly, right? There is no loss of signal because it's kind of got lots of insulation. So it gets from point A to B without losing energy, without losing its signal, and gets there in kind of robust manner. So that's heavily myelinated. Large diameter also contributes for the ability for that neuron to convey by speed. Okay? So that's kind of important because, for example, vibration, your sensory organ that picks up vibration has to be able to pick up the actual hertz, the oscillation of that vibration, and notice the difference of when it's on and when it's off. There is a vibration frequency that is too fast for you to ever feel it. You will never notice it. So there is a limit, but you can see with something like vibration, we need to have heavy myelination, very, very fast conduction. So this all works together, okay? So that kind of information comes in trigeminal ganglion number 1. That's our first neuron. And then it synapses in the main sensory. So one of these little brown dots is the main sensory nucleus. So that's its first stop. Synapse is there. And then neuron number 2, which is the main sensory neuron, that's where it is originating, crosses to the other side. Okay? And then it ascends through the medial lemniscus, which I think you became familiar with Friday as part of the sensory pathway, right? The gracilis cuneatus cross in the medulla and join the medial lemniscus. The posterior dorsal column pathway joins the medial lemniscus. Well, that's all of this. So the face sensory eventually joins the rest of the body sensory. Same pathway, the medial lemniscus. Neuron number 2 ascending to finally meet neuron number 3, which is the cell bodies in the thalamus. And neuron number 3 will go off to Brodmann's area 312. Okay? So 3 neurons. This is a very typical sensory pathway. You'll see it again and again in subsequent lectures. Any questions? Yes, Felix.
So it goes from 1 to 2 to the dorsal column. In this case, it's going to the gracilis.
No. So these are from the face.
Right.
The trigeminal field is face. If you want to talk about the rest of the body, that's here. So these are in the dorsal root ganglion, and they enter and join the dorsal column. Okay, dorsal, and then you can divide those into fasciculus gracilis, fasciculus cuneatus, depending on where you're coming from. And then here's what you guys covered on Friday. This is the caudal medulla. We have the 2 nucleus gracilis, the 2 nucleus cuneatus, and then they'll cross and join the medial meniscus on the opposite side. So that's how sensory from my left side of my body makes it to my right Brodmann's area 312. For most of my body, they cross at the medulla. For my face, they cross up here in the upper part, my rostral kind of pons area, and does so right at the main sensory, at the level they come in. Okay, does that make sense? And eventually, once they're in the medial meniscus, they go with everybody. Everybody's the same. They go to the thalamus and they go to 312. The whole body and the face is now represented. Okay? It's just that the trigeminal joins a little later. Make sense? Okay, so that's main sensory. Emily?
What thalamus nucleus does it?
It'll be VP, VPL, VPM, depending, but we got a whole lecture on just the thalamus. So thalamus is good for today, okay? Any other questions? But thinking ahead, okay? All right. Yeah, the only thing I'll make a small note, it's not a big deal. Not every fiber of the main sensory cell group will cross over. A few will stay ipsilateral, and they will go to the opposite thalamus through the dorsal trigeminal tract, okay? Just for trivia's sake, okay? So just know there's a different track on the ipsilateral side. For dentists, this might be important. We don't know why, what the rationale is why some don't cross over. It's still a bit of a mystery, but it's not the majority. The majority, you can see they make it a tiny thin line. The majority will cross and join the medial meniscus, okay? But just to be thorough. Okay. The trigeminal spinal nucleus. This type of sensory information is about facial pain and temperature. So these are governed by small diameter, either poorly or non-myelinated fibers. And all pain fibers are like this. They're really tiny, sometimes are naked, have naked processes, and they make for very poor conduction. So if you ever hurt yourself, did you ever notice there's a moment where it's just enough time to curse a couple of times before the pain actually arrives? Or you see a little kid bonk his head on the coffee table, and then he's thinking about it, and then the air sucks in, and then the wailing starts. It's a really slow-mo thing, right? And that is because pain information travels so slowly, because it's in this really small diameter, and the information gets leaked and dissipated along the way. So it takes some time. So in this case, these, again, coming in, our first neuron is the trigeminal ganglion. However, these neurons, and here's the main sensory right here, you can kind of see it better. They skip the main sensory, they dive down further, lower to the brainstem, and they finally synapse at the spinal trigeminal nucleus. Okay, and so this is in the caudal medulla, right? We've gone down away from the big brain, and then it finally synapses. That second neuron is here in the spinal trigeminal. That neuron crosses, and then that ascends through the anterolateral pathway, joining all the other pain information coming from the rest of the body. So neuron number 1 is up here, neuron number 2 out of the spinal trigeminal, neuron number 3, same thing, thalamus, the VP, on its way to 312. So neuron number 3 is in the thalamus, okay? Very kind of organized. Make sense? Notice that pain and somatic, or tactile somatic information, a lot of big difference in where they're located. This becomes important later because you'll find case studies where only the pain temperature is disabled, but the fine touch is not, or vice versa. Because of this distance, we can start to have very different presentation of sensory processing, sensory function, okay? Okay.
Dr. Choi.
Yes.
So spinal, or neuron number 1 is in these caudal.
Trigeminal ganglion, number 1. Because it's a ganglion, it's always outside, so that's why the little stick and ball representing the cell body is out there, okay? And then the second one is in the spinal trigeminal. That nucleus houses those neurons. And then the third neuron is a thalamic neuron. Make sense? Does that answer your question?
Yeah.
Okay. Any other questions?
Okay, wait, I have one more.
Yes.
And so then they synapse, like one synapse is in the caudal, and that's when 2 goes
Yep.
up?
Yep. So it's a relay. So the trigeminal ganglion will synapse on a group of spinal trigeminal nuclei cell bodies, and then their axons will ascend to the thalamus and activate a thalamic neuron, and their axons go to 312, Brodmann's area 312. Felix.
Is this still considered an ascending pathway?
Yes.
Okay.
Always ascending because we're targeting the brain. The descending is the brain sending information out. Patrick?
Oh, sorry.
Oh, you're just waving your pencil at me. Okay.
Sorry.
That's all right. Anyone else? Okay. Okay, so a different kind of schematic. We're going to talk about number 1 here. This is the mesencephalic nucleus of the trigeminal. And this is considered a pseudo-unipolar neuron. This is the exception to the rule. The cell body is inside the CNS, okay? So let's orient ourselves what's going on here. So number 1 is the mesencephalic, just for clarity. Number 2, you can see is a very thick line, is the trigeminal main sensory. So it's the fine touch, vibration, proprioception. The cell body you can see is outside. You see the cell body stick and ball. And then you can see its synapse right here at the main sensory nucleus. Number 4 is our spinal trigeminal, right? Again, the cell body out here, but its diameter is, the line is thinner to represent that poorly myelinated small diameter fiber. And then you can see it descend and synapse here at the spinal trigeminal nucleus. And then they go on up from there, okay? So we're talking about, in this case, 1. A pseudo-unipolar means the cell body is here in the mesencephalic nucleus, okay? And so what happens is sensory information comes in here, which is the same cell, basically, and it goes right back out its own dendrite to the motor nucleus. So it's a U-turn, all right? So it is important for jaw reflex. So it's picking up stretch receptors in the jaw muscle. And then their main target is the trigeminal motor nucleus. Okay? So these stretch receptors are important for muscles of mastication. So any muscle that's involved with rotating your jaw up and down or side to side, a little, when you crunch, your jaw comes forward, comes in, goes side to side and up and down, all those important movements to accommodate whatever you're rolling around in your mouth. It's also taking in information from your gums, your teeth, your palate. Primarily because think about it, what happens when you're enjoying popcorn, which is a crunchy item, but you hit that kernel that didn't pop, right? And it is a solid rock. You're not going to bite through it. And so what do? Do you drive your jaw harder into that kernel, or do you just detect it and you kind of take the pressure off? That reflex is this, governed by this mesencephalic neuron. So when that stretch receptor finally meets a certain stretch and some opposition, it will then react to the information by creating some other motor command, okay? So how we do it is information coming in about stretch, and then it immediately goes out and hits this motor nucleus, and then the trigeminal motor nucleus changes activity in the motor, the muscles of mastication. So it's a quick reflexive, it doesn't have to go anywhere, so the speed in which this can detect and emit a motion or a motor command is nearly instantaneous. Yeah.
Is lockjaw something like muscular?
It is muscular, but it's not related to this cranial nerve. Yeah, no, it's kind of a paralysis of all this, but yeah.
What pathway would tell you consciously what happened? Does that go through the same thing, or is that different?
No, consciously, then your number 2 would come in and say, wow, you detected the corn kernel, you knew what was happening. All that information is being sent to the main sensory. And if you bit down and it was really painful, like in the gums, like you really pounded it before you gave up on it, then that's going through the spinal trigeminal. So the trigeminal neuron will convey a lot of simultaneous information and emit and eject a quick motor response, like back off, right? Let that go. So one of the reflexes, a deep tendon reflex that we can use that's involved with this cranial nerve is the jaw jerk. And we'll see it at near the clinical side of the class, where you take a reflex hammer, an individual has their mouth open just a little bit and try to be in a relaxed state, and then you tap their chin with the hammer. What you're looking for is the jaw to bounce back. And the jaw should bounce back very subtly, but if there's pathology, it'll bounce harder, because in cortical pathology, if you lesion the cortex, all your reflexes become more pronounced and exaggerated. Your patellar reflex, your Achilles reflex, all of them will have an exaggerated reaction. So that's the first test we can do to detect if there's cortical, because part of the role of your cortex is to inhibit reflexes. And so when it's been disabled, your reflexes have less inhibition, they become stronger, more robust, okay? So the jaw jerk is using this circuitry when we test that, okay? All right, questions? Okay.
Yeah.
Yes. Oh, Emily.
Is this a 2-neuron pathway then?
Yes, it's a pseudo-unipolar, but it's still a neuron. It's a simple, like most reflexes, it's a very simple circuit. So for example, the patellar reflex you see all the time, tap the hammer on the knee, it only takes 2 neurons, 1 sensory neuron, 1 motor neuron, same thing. 1 sensory neuron, 1 motor neuron, and we have that jaw jerk. Okay? Yeah.
But it's coming back on the same neuron?
Yep, that's why it's kind of unique. It's pseudo-unipolar. Yep. Owen.
So 3 labeled on this would be a motor neuron?
Yep, 3 is now the motor neuron, and the one we're going to hit next. This one has all 4 of the targets. Okay? So, number 3, or the orange one, is the trigeminal motor nucleus, okay? And these go to the mandibular and all the muscles of mastication. So all of these maxillary mandibular areas to lift your jaw, to make your jaw go left to right or back and forth. So as you roll, imagine like a gumball, like a really big hard candy. You notice your jaws rotating and going in all kinds of different directions. That is all these muscles of mastication, right? Often, however, the cortex, because we know we have mouth, face muscles on our homunculus, a lot of these are bilaterally innervated. So we don't know how, we can't really activate only my left jaw muscles. They're always working symmetrically because chewing requires symmetrical movement. So there are some muscles built into our body that will never work independently. They always work together. They tend to be the trunk and back, these core girdle muscles. You can't really just contract one and not the other, right? Same with the jaw, okay? This image is just a more complex image. The trigeminal motor nucleus is still orange. So if you kind of follow, you have to do this on your own version, but you can follow the orange and you can see all the different places where the muscles are being affected by that motor nucleus. So we go all the way up into the temples so that, kind of helps to, when you see these muscles here pull on the jaw. The easiest way to see this is when you look on dogs. These muscles are super strong from the temple to the top of the jaw. Those are the dogs that have the death grip, that they can grab on something with their jaws and you cannot make them open it. It's because they have such a strong connection here. We don't have such strong, so someone could pry it open, but other animals show a lot more elaborate circuitry there. Okay, that is the trigeminal. Trigeminal is primarily sensory, but we have a little bit of motor. This motor is certainly not the primary motor driving facial expression or facial movement. We have a whole cranial nerve for that, but it is enough for the chewing side of what we do with that muscle, okay? Okay, questions? Okay. So, quick review, cranial nerve 5, trigeminal, sensory, the primary sensory, which is touch, vibration, proprioception is the main sensory nucleus. Pain is coming out of the spinal trigeminal. The reflex, based on stretch receptor information, is through the mesencephalic, and I spelled it wrong, mesencephalic nucleus, and the motor is coming out of the trigeminal motor, okay? All right, abducens. This is another and last ocular motor controlling cranial nerve. Its function is to govern the lateral rectus muscle. Okay. So abducens, to abduct. It's the easy way to remember is you abduct something away from something, you take away. So this is abduction away from the midline, right? You're pulling away from the midline. So abduction is this eye going away from the midline. Adduction, adduction, is the midline going, is the other eye going towards the middle. So you have one eye is always abducting and the other one is adducting, okay? So if you're into weights, you have the adductor muscles, abductor muscles. So, but otherwise, we're just going to sound funny in the class. Okay? Any questions? Okay. Now, the abducens controls the lateral rectus. So let's think about this example. Oh, before I say that, it comes from the abducens nuclei. Okay? Which is a straightforward nucleus to the cranial nerve, so nothing funny about that. So in our scenario, imagine a left abducens nerve damage. Remember, when we look at these images, it's always to the patient, not to you. So this is left, okay, their left eye. So we have a left abducens nerve damage. So the first thing you want to do is, what does the patient's eyes present when they're just looking forward, right? So notice here that there is a little misalignment between the two eyes. So you can kind of assess how much sclera, how much white there is. There's a little less white here than there is here. So that means the left eye is adducting a little bit more than it should. And that's, we have medial rectus and lateral rectus, they're always pulling together to keep you in line. So when we lose an abductor, the adductor is unopposed, and so the eye pulls overly towards the medial side. Make sense? So we have a medial strabismus. Strabismus, and the next word I'm going to show you, strabismus, is a misalignment of your eyes. So look at the very center of your pupils, and that's what you're trying to compare between two eyes. They don't line up, and so when they don't line up and one is off center from the other, you get diplopia, which is double vision or blurry vision, because you have two images now that are not overlaying, okay? So here is looking straight ahead. We have already medial strabismus because the left eye is unopposed, the medial rectus is unopposed, so there is a mismatch. Now, we're going to ask the patient, we'll do this one. We're going to ask the patient to look to the right, okay? So to look to the right, my right eye has to use the abducens, right? Pull to the left. My left eye has to use ocular motor 3, the medial rectus, pull to the right. Since 3 in the left is fine, and then 6 in the right is fine, it moves fine. So we have no visual deficit, no strabismus, no diplopia, okay? But now we're gonna pull to the left. To pull to the left, my right eye has to pull on the medial rectus. My left eye has to pull on the lateral rectus, but in this patient is suffering damage to the nerve. So it can't pull, okay? So my right eye pulls medially, my left eye kind of hangs out. And that's what we get here. You see here the right eye is moving towards the nose, and then here there's no movement of the left eye towards the temple. That's a severe strabismus. It's a severe medial strabismus. And the blurriness is even worse for this individual having to look towards the left. Okay? Does that make sense? Okay. Now, there is an instance involving the abducens when you get this. You get this, and that's fine. But then all of a sudden, you ask the patient to look to the left, and both eyes are paralyzed. What gives? Okay, so to understand this, we need to go one step further. There is an interneuron that connects abducens with ocular motor 3. So ocular motor 3 has the medial rectus, this is the lateral rectus. We know our eyes are always moving together. They never deviate in any degree, otherwise we would have blurry vision. So we are very clever with having the exact precise movement between the two eyes. To achieve that, we need this interneuron, the MLF, called the medial longitudinal fasciculus, okay, shares its cell body inside with the abducens nerve cell body. So this is the abducens nuclei, and up here is the ocular motor nuclei, okay? Very far apart. So the abducens nerve comes out of this nuclei, and when it's activated, not only does the abducens nerve fire, but the medial longitudinal fasciculus will fire. The MLF immediately crosses to the other side, is now traveling on the contralateral side, and then activates the contralateral ocular motor nerve. So together, when this fires, this fires. Does that make sense? Does everyone understand that? Because it's going to get a little more complex. Make sure you understand it up to this point, yeah? Okay. This is how we get concentric movement between the two eyes. So, in the original case up here, how is it that with left abducens nerve damage, do we actually result in paralysis of the opposite eye? We can see it from here. In this case, it would be scenario B. Not only did we affect cranial nerve 6, but we damaged the entire abducens nucleus. That's where the damage is. So by damaging the nucleus, my abducens doesn't work. And now my MLF, my medial longitudinal fasciculus, won't send that signal. And so therefore, the opposite eye, which is right, will not move. And that's how we get that example. Does that make sense? So the distinction is when you are diagnosing, is it just the nerve? Is it the nucleus, the small box? Or in the next slide, I'll give you 2 more scenarios, okay? Yes, Aya.
So is oculomotor traveling to abducens?
Nope.
It's a
Nope,
pathway?
it is abducens traveling to ocular motor.
And the interneuron is the MLF, and when you get both eyes are paralyzed, it's which nucleus is damaged?
Oh, it's the abducens nucleus here. Yeah. If you damage the ocular motor, which we know is very improbable, because notice how close they are, so to impact one and not the other is improbable. It is more likely that you can hit the abducens nuclei because they are not sitting so close to each other. You can damage one and not affect the other, right? There's enough space in between, okay? Yes?
Regardless if you damage the abducens nucleus, do all functions of the ocular motor nerve cease to stop?
No,
Okay.
you would still have pupillary reflex. It's only the coordination of the medial rectus. Yeah. You should have up and down vertical movement. You should have the pupillary reflex. You should not have accommodation reflex. Would you have accommodation? You may have accommodation because it's both medial rectus pulling together. So it's unrelated to the lateral rectus. I don't know how much this influences, but yeah, I'll go with that. That's a good question, okay? Any questions? Okay, so let's make this one step more complicated. So we did A, which is damaging the nerve. We did B, damaging the nucleus, okay? Now we're gonna do C, which is damaging just the MLF. What does that look like? And just the MLF on one side. Okay, so that's what this panel. So, I think a way to address your notes, and this has kind of helped me learn it way back in the day, was I would kind of make here's how the world works. So, for example, this right abducens is going to pull laterally to the right, and this abducens is going to pull laterally to the left. Just to make sure we're clear, this ocular motor is going to pull medially to the left, okay, and this one's going to pull medially to the right. Okay, so the arrows are kind of opposite. So let's look when you ask the individual to look straight ahead. Nobody's pulling anything, just in neutral position. My abducens are unimpeded, and my ocular motor is also unimpeded, so we have a balance, so they should be able to look forward with no strabismus. There's no unopposed force. They're equally present. So there's a medial and a lateral on each side. So that's fine. We're going to look left now. So in order to look left, we have to take the left eye and pull laterally. Okay, so we need this one. And we need the right eye to pull medially. We need that one. So you can see I need this one and this one to work together. And there's no reason why this can't function, and there's no reason that the oculomotor 3 here doesn't function, right? Because we're using the far right medial longitudinal fasciculus. But when we go to look to the right, we just did left, the right eye has to pull laterally, so I need this purple neuron to work, which seems fine. But then I need the left eye to pull to the right. Okay, so we're going this way. So in order to tell that cranial nerve nuclei to do something, I need this medial longitudinal fasciculus to reach out to 3, but you can see that's where our lesion is. So we don't send any information. So in this case, only the right eye. So we have the right eye is moving laterally, but my left eye is now paralyzed, is not moving medially. Okay? It's going to take a little time for you to find your own schematic and work the logic. But I always like these arrows because this one and this one work together, this one and this one work together. So try something like that. Okay? Okay, one more time. Yes?
So you're basically saying that the right eye, for attempted gaze to the right, is able to laterally pull to the right because the lesion is farther along than.
It's on the opposite side. So here, this purple neuron has no reason not being able to reach its muscle and pull laterally to the right. However, when this nuclei, abducens nuclei, also sends simultaneously a signal to the MLF, that MLF immediately crosses to get to the opposite ocular motor. And that's where that's where the lesion is on that MLF. Okay. Make sense? Okay. All right, one more. It's called a 1.5. It's very rare. In this case, we have a lesion this big. Okay, so this is D. So what's involved in this lesion is this abducens nerve, this MLF nerve, and it's cut and caught some of the other MLF for the other side. So you can see that's in the corner. So we have impacted both MLFs and this one abducens. So when we look straight ahead, okay, by looking straight ahead, I have no function of this cranial abducens. Okay, so my left lateral is not pulling as much against my left medial. So my left lateral is going to have a little medial kind of twinge to it. So you can see my left eye has a little less white sclera than my right eye, okay? Because the medial rectus has nobody to oppose it. So I already start with medial strabismus. Let's go over here. If I attempt to look to the left, right? In order to look to the left, I've got to move laterally, left, and this one medially to the left. But this one is not going to move laterally because I've already impacted the abducens, and I am not able to send information through the MLF because that's involved as well. So this one is not going to get a signal to move. So I should have paralysis. So we have paralysis of gaze to the left. No eye is going to move. Okay? Finally, when we attempt to look to the right, right? So then I need to have this one work, and I need to have this one work. So in this case, this one is going to work fine. It's not impacting this purple abducens nerve to get to my my right lateral rectus. But where am I? I'm looking to the right. But this information that's being sent by this abducens can't make it to the opposite ocular motor because it got clipped in this lesion. The lesion was big enough to now impact that. So now I will not have my left eye moving to the right. So here we have my right eye moving, but my left eye does not. So this is the 1.5 presentation. Okay? Very complicated. Felix?
So with this type of lesion, 1.5, your left eye always looking straight.
No, it just means that when you are looking in either direction, your vision will become clear or less clear, or even more or less clear, depending on how far you stretch that strabismus, right? You will, and like in the case on the right where both eyes are paralyzed, right? You might not be able to line them up. Maybe you can in their paralysis, they're lined up, but unlikely because of this. Because you have a pair, a medial rectus and a lateral rectus that are unpaired. So there'll be an exaggeration of the medial rectus pulling inward. So it's probably you're gonna have blurry vision in almost every scenario for the 1.5. It doesn't mean that they can't move in other directions, it's just in these particular left and right.
Okay.
Anyone else? Okay. All right, that's it for this one. Abducens, simple nerve turned out not to be so simple. Okay? All right. All right, we'll do facial, and we'll think about taking a 2-3 minute break to ease the heat load on your brain. So in the facial nerve, this is your primarily a motor. So this is facial function is facial motor, and it has some parasympathetics. Okay. Also a little bit of sensory. So this is another one of those mixed nerves. It has 4 basic big functions. So we'll start out with one, the motor. We begin with the facial motor nucleus, okay, which is in the pons. And the facial motor nucleus innervates the upper face and innervates the lower face. What is interesting about the upper face is that it has bilateral cortex input, whereas the lower face has unilateral cortex input. So let me explain. Okay. So here's our facial motor nucleus sitting in our pons. We have 2 kinds of neurons, the ones that govern the upper face and ones that govern the lower face. So that's the red and the blue neurons. The upper face neurons get input from the face homunculus, our motor face homunculus, but the upper face gets from both sides, okay? The lower face, as you would imagine, gets from the contralateral side. So this being the left motor nucleus becomes the right homunculus, the motor cortex, the Brodmann's 4. The right side is then reaching and crossing somewhere, there's no specific spot, crossing somewhere to the facial motor nucleus. We understand? Okay. So sensory information ascends in a 3 neuron relay. Motor information or motor commands descend in a 2 neuron relay. And therefore we call the first one, usually the one that's up in the cortex, the upper motor neuron, and the second one somewhere else, the lower motor neuron. So this would be the upper motor neuron, and in this case, this would be the lower motor neuron, because there's only 2. So if you have an upper motor neuron lesion, eye lesion the face area, eye lesion the internal capsule, maybe eye lesion the cerebral peduncle. My upper face is not going to show paralysis because it has the other cortical side to take it over. So we tend to not see paralysis when it's an upper motor neuron lesion, okay, because we have 2 cortexes. However, after they synapse in the facial motor nucleus, if they then damage it anywhere from this point to where it lands on the face, it becomes a lower motor neuron lesion, and we are likely to have a full hemiface paralysis, upper and lower. Does that make sense? Now, if we damage part of the cortex, the homunculus, that is destined for the lower face, that is only unilaterally directed. So this blue neuron, if we lesioned up in the cortex or the peduncles or the internal capsule, that facial motor neuron, the lower motor neuron, doesn't have another source of information. So you'll see lower face paralysis. Okay? Not upper face paralysis, but lower face paralysis. Does that make sense? So upper motor neuron lesions tend to leave you with only lower facial paralysis. Lower motor neuron lesions leave you with full hemifacial paralysis. Does that make sense? You guys look tired.
No,
No? It doesn't make sense.
we're not tired.
Okay. Owen, I'm not sure you represent the class, but I appreciate it. Okay? Now, what's interesting is this facial nerve, this facial motor nerve governs the corneal reflex. And I don't know if I remember saying it when we got to the trigeminal, but any reflex needs kind of a 2-neuron circuit. So the trigeminal is the sensory neuron, and the facial is the motor side. So the corneal reflex is a test where you take out, like, pull out a few wisps from a Q-tip, a little cotton ball, just a few hairs, and you actually touch gently the surface of someone's cornea. This is a survival instinct. If I have something touching one eye, both eyes blink. Okay. So if you have an aberration in the way you respond to that reflex, it could either be the trigeminal is not conveying the sensory input at the cornea, or your facial nerve is not conveying the motor reaction. So the corneal reflex becomes a very important reflex to check to see, do I have trigeminal sensory loss or do I have facial motor loss? Okay? The reflex works regardless of which eye I touch, both eyes have to blink. All right. All right. Number 2 is the superior salivatory nucleus. Okay. So this is the parasympathetic. Okay. And the superior salivatory nucleus contacts the pterygopalatine or the sphenopalatine ganglion. I'll write them both out. Pterygopalatine, also called the sphenopalatine. Oops, not palatine. Ganglion. So ganglion tells me it's a group of cells outside of the CNS. Okay? And this ganglion innervates the lacrimal glands as well as the nasal mucosa. Okay? Lacrimal glands are your tear glands. So the superior salivatory nucleus of the facial cranial nerve creates your ability to cry. And you notice when you cry, you make snot. It's always hand in hand. It would be lovely to cry gracefully without the, right? But you can't, they're connected right here. So when you cry or tears are made, your nose always starts to run. And this is the circuitry. This is an autonomic reaction. You can't control it, so therefore it belongs in the parasympathetic arm of the autonomic nervous system. Questions? So lacrimal glands are tear glands. Okay. 3 is the nucleus of the solitary tract. I'm going to call the NTS because that's nucleus tractus solitarius, the NTS. Okay, so this is sensory information coming to the NTS from different locations, but for this case, it is the anterior 2/3 of the tongue. So it's providing taste information. but only from the anterior 2/3 of the tongue, sending it to the NTS, the nucleus of the solitary tract. Okay, so there's our special somatic element. And the last is the spinal trigeminal. Sound familiar? Same one. Trigeminal nucleus, same one that we just did. And it receives information from the skin of the external ear. Okay, so your little pinna here. So the skin in the back and your earlobes, that information, especially the pain information, is going to the spinal trigeminal nucleus via the facial cranial nerve, number 7. Questions? So let's think about it. What is the most common pathology of facial cranial nerve? It is Bell's palsy. I don't know if you've known anybody with Bell's palsy. Anyone? Anyone? There you go. So the biggest symptom in Bell's palsy, it's an inflammation of this big cranial nerve on one side. And the biggest one is you have a drooping face because you have no motor control. So, you know, it's just pretty much not moving. Your smile is asymmetrical. There's no smile, there's no movement. Depending on how high up, you may keep your upper face, or you may have the total paralysis. Chris, who drives the cave, one year had Bell's palsy. So it was perfect. He was helping me out in the neuroanatomy lab, and he was showing me cranial nerve pathology. So in Bell's palsy, we have the facial paralysis. Paralysis. Do I have another one? Yeah, I'll write it here. It's just Bell's palsy, facial motor paralysis. And so a couple of the other things that it does. You have hyperacusis, meaning sound much, much louder on that side. And that's because the cranial nerve 7 has a role in dampening those small ossicles you have in your inner ear, the smallest bones you have in your body, the stapes, the stirrup, the hammer, the anvil, or the stapes, the malleus, and the incus. They require a little cranial nerve 7 to kind of keep them from bouncing around too much. So without that, you have hyperacusis, that they're kind of moving a little bit more exaggeratedly without that inhibition. So that tracks. Dry eye. So you know that we have that parasympathetic connection to the lacrimal glands, so that seems logical that you would have dry eye. And then loss of taste. You usually don't lose taste, but you have a reduction of taste. Because taste, because of the saliva, it just smears your signal around so immediately. You really can't tell that it's the anterior 2/3 of half of my tongue, right? So, okay. So all these symptoms track our understanding of our cranial nerve. We can see it here in the facial motor, we can see it in the tear production, we can see it in the taste, we can see it in other symptoms of external ear, lack of, feeling not quite, a little numb, not quite conveying that, okay? Other interesting things about that is when it heals, when Bell's palsy heals, sometimes they heal incorrectly. So sometimes there's a mismatch when people, for example, see food coming, like they're starving, they're just sitting down at a restaurant, their favorite food sits down, and they start to cry. Because instead of salivating, which is the reflex they should be having, their tears, their lacrimal glands kind of cross-wired. So they start to tear up. Okay? So that's been known to happen. Okay, Emily.
So why is Bell's palsy so misdiagnosed as a stroke?
know why it is. I mean, there are certain things that should give it away that it isn't. I can see you through the paralysis is probably the first thing you think of. Oh my gosh, I'm having a stroke. I can't move half my face. But a good neurologist should then be able to kind of do the differential of like, well, what else is going on? And remember, what's in the homunculus, right? What's next to the face in the homunculus? Anybody? Hands, right? If you don't see hand paralysis or even a hint of hand paralysis, yes, it's possible to just hit the face, but it's less probable, right? And so this is us in our clinical half of our class. You have to decide, am I at the nerve, because that's more clean and isolated, or am I in the cortex and do I see other things coming along with it? That would be one precise lesion in the cortex. It's possible, but less probable, right? So that's why someone just jumped to the gun and didn't make that. Well, let me just double check a couple other things that should coincide, okay?
What causes it?
They don't know. It's an inflammation, maybe viral inflammation, they think, of the facial nerve running right along the side. I don't know. I had a friend's mom get it, and she thought it was because she slept with the window open on a cold evening, and so her face was kind of always cold the whole night. I don't really know if that does that, but you know, usually antiviral, anti-inflammatories are the course of action. Yes?
I got Bell's palsy in high school from getting a soccer ball kicked at my face.
That I could understand, right? You've ruptured and damaged a cranial nerve. Did you have all these symptoms? Not
so
to
much the
violate all your
hyperacusis,
HIPAA
yeah.
rights? Was it?
Not so much the hyperacusis, but everything else, yeah.
Yeah, yeah. So isn't it fun when the anatomy works out? I think that's really cool. Yeah, in many years, somebody's always bringing me some medical records. So we've had lots of disclosures. It's quite interesting to see you all. Yeah, Emily.
So does the hyperacusis, the dry eye, and the loss of, well, hyperacusis is one side, but the dry eye and loss of taste, is it unilateral?
Yes.
Oh.
Yes, but like I said, the tongue, because you smear saliva, it's very hard to really, it's really just half of the front part of my tongue. You don't really detect that, but you just might feel like, I just don't taste as well. It seems a little dull. Or I burnt my tongue on a side. You know. Okay, I'm gonna give you a few minutes break. I can't give you too long because I wanna be able to finish. But we're in the home stretch. Okay, so let me give you like literally 2 minutes and then be back in the room. Does anyone want me to back up to a slide? I know there was a lot of text. No, you're good? Yes, Bridget.
When you said it was proprioception, was it like, is that both unconscious and conscious proprioception, or is it just?
For what was the first part of your question?
For trigeminal.
Yes.
You said it was like proprioception. Is that both conscious and unconscious proprioception?
It's, I mean, I don't know if there's a way to distinguish the circuitry for something like that, whether you're aware or not aware of certain proprioception. In this case, it's proprioception of the jaw. So do you know if your jaw is open or closed without having to look at yourself in the mirror? Yeah. So it's more, there is a conscious element to that, but there's also, if your mouth is hanging open for your daydreaming, there's an unconscious component to it. Yeah.
Does the inflammation from Bell's palsy ever affect the trigeminal nerve causing trigeminal neuralgia? Would it be close to that?
I don't know. I guess so, but I don't know how related they are. Sorry, I have to keep my phone on. My family is on like medical. So It's a good question. Maybe if you have a kind of systemic infection, you could see something like that. But I don't think Bell's palsy itself. It's very selective to that one cranial nerve, and I'm not sure why.
Do you know if Bell's palsy, like if you have inflammation, does that increase your risk for MS?
I don't think so. I think MS has such clear origins with kind of cytokine and inflammatory markers that, and it's so systemic. So certainly Bell's palsy could be an element in MS, but it doesn't mean that MS and Bell's palsy are always linked together. Yeah. But those are good questions. Yeah, yeah. All right, we all back? All right, let's wait for Michael. So the next cranial nerve is auditory vestibular, vestibulocochlear. This one's very clear. The function is hearing and vestibular function, balance. Okay. We're not going to get into it in real detail. We're just going to kind of confirm it right now because we have a whole lecture on the auditory system and the vestibular system that comes at the end of the semester. So you just need to be aware of how they're kind of circuited, and we're going to do the very brief treatment here. So we have hair cells in the cochlea, which is your hearing organ, and then they will project to the cochlear nuclei, and then they go to the inferior colliculus, to the medial geniculate nucleus, and to Brodmann's area 41. That's our primary auditory cortex. Okay? That's all you gotta know right now. We'll get into all the special mechanoreceptors later. Now, that's auditory. For the vestibular, we can start with the semicircular canals, the utricle, the saccule. These are the actual mechanoreceptors in the inner ear, giving us information about motion, and they generally terminate at the vestibular nuclei. Okay. And then from there, they spray out to everywhere. So two big areas that they end up going to is the spinal cord and the brainstem. But they'll go almost anywhere else. But these are the two big targets. The brainstem helps with the MLF, right? In order for you to orient, for example, if you notice that in order to keep an image static in your field of view, as you turn your head, and I keep you all in my field of view, as every degree I turn my head in one direction, my eyes turn in the opposite direction, the exact same number of degrees. That is conveyed by this particular circuit, and then involving the brainstem, abducens, and oculomotor, okay, to pull that off. So knowing where your head is turning, conveying that information to your eyes, the extraocular muscles of the eyes, okay? Then we're done with that one. Any questions? Okay. All right, number 9, the glossopharyngeal. As the name implies, the function of this is tongue and throat. So it is a conveyor of taste and pharyngeal sensations in the oral cavity, the tongue and throat. So again, just like the facial, it comes in 4 functions: the motor function, a sensory function, a special sensory, etc. So we're going to do the same kind of dividing. So in the motor, we start with the nucleus ambiguus. Lovely name. Okay, and it supplies the stylopharyngeus muscle. which elevates the pharynx when you're talking and swallowing. So it involves talking, swallowing, and gag reflex. Okay? So one way to test this, and this is what happens when you go to the doctor and he's shining a light in there and say, ah, when you say ah, you use this cranial nerve, your palate elevates. That stylopharyngeal muscle elevates so he can see further down your throat. That's why the ah is there, okay? The gag reflex also requires that muscle to kind of contract and relax. Now, the other one is the inferior salivatory. So make sure you have a way of separating superior salivatory. This is our parasympathetic, but not tear ducts or tear glands. This is going to the otic ganglion. And then the otic ganglion innervates the parotid gland, which is another one that makes saliva. It's a big one in your cheek. Okay? So parasympathetic, it's right here. Okay? We have another NTS, nucleus tractus solitarius, or the nucleus of the solitary tract, and it's receiving information about taste from the posterior 1/3 of the tongue. Okay? So taste information, this is our special sense, or visceral sense. Okay? And then the 4th is the spinal trigeminal nucleus. And as you might imagine, it is giving information. In this case, it provides touch, pain, and temperature information from the tongue, pharynx, middle ear, and of course the skin of our external ear. Okay, a little bit more diverse than the facial. Okay, does that make sense? So we have a motor component, a parasympathetic component, a special sense, and a regular sense. That's generally the organization. Felix.
For the NTS, is it posterior 1/3 or 1/2?
Oh, sorry. 1/3.
Okay, thank you.
Let's just have it 1/3. Okay.
Under nucleus and nucleus, what does it say right above swallow?
Nucleus and stylopharyngeus. Oh, under swallow, the gag reflex.
Or right above swallow?
Talking.
Oh.
So when you talk, you have to elevate your palate as well. You don't realize it, but certain vowel pronunciations make that go up and down to pull off the pronunciation. Okay? Anybody else? Manage my atrocious handwriting.
So what's the taste for the posterior?
Yes, taste. So now we have the whole tongue. The anterior 2/3 and the posterior 1/3. Okay? Yes, Felix.
Will we need to go in depth about like tongue receptors, like if the patient can't taste like sweet or anything like that?
No, it covers them all.
Okay.
Yep. Yep. All right. Very good. All right. Vagus is again similarly organized. Vagus means a wanderer, a vagabond is a wandering, and so a wanderer, and the vagus nerve is considered a wandering nerve because it's extensive reach. So even though it's in the brain here, it'll go as far down as the upper jejunum, right, into your intestine. So it tracks your esophagus, it jumps off to your heart, cardiac muscle, continues and innervates your stomach, and then goes down to the duodenum, and then the upper levels of your intestine, of your small intestine. So that's a long distance for a brain cranial nerve to innervate, but this is the one that's always involved in seasickness and in digestion, and so the vagus has a huge amount of impact on that kind of cardiac and digestive physiology. Okay, so just like the others, it is a motor parasympathetic. It's probably the parasympathetic output is its major function. Regulation. Okay, so in terms of function, because of its wandering distance. So, one, there is the motor component. So again, the nucleus ambiguous appears. Okay, and in this case, the nucleus ambiguous is innervating the striated muscles, the regular muscles, not smooth, of the larynx. Oops, let me start this again. Larynx and pharynx. Okay. So this contributes to your ability to swallow. It also contributes to the gag reflex. How do I determine it between the glossopharyngeal? Well, because this has the laryngeal part. So the damage to the vagus nerves often leaves the patient very hoarse. They can't control their vocal cords. They can't contract them, so they have a very whispery, very no voice coming through. And so that usually helps you distinguish this from glossopharyngeal. Okay? So larynx and pharynx, swallowing, gag reflex, voice box. 2, the parasympathetic component comes from the dorsal motor nucleus of the vagus. The vagus is cranial nerve 10, so you'll see it as marked as an X. So DMX is a very common abbreviation for this component of the vagus. Okay, and so the dorsal motor nucleus of the vagus, it's going to the thoracic cavity, the abdominal, so all those things that I just spelled out to you, the heart, the lungs, the digestive tract, this is how it gets there, through the DMX. Okay? 3, we have again the NTS, and we have again a sense of taste, but this is taste information from the epiglottis. Which is way back there. A lot of bad, bitter taste conveyance. Okay? And then 4 is the spinal, trigeminal nucleus. Okay? And this is getting information from the pharynx, larynx, meninges, and of course this skin from the external ear. Okay? Any questions? Pretty straightforward. There is a large memorization component to these cranial nerves. If there is some way, cards, posters, repetition, it's all memorization. It's not hard. Okay? It's just a lot. Don't think I won't pull off the difference between the inferior and superior salivatory nucleus. Seems like an obvious way to test, right? Hint, hint, hint. Okay? Okay. Let me keep you on track. Oh, quick review. So we have done the abducens, which controls the lateral rectus. We've done 8, auditory vestibular, which is a straightforward sensory cranial nerve. Then we have 7, 9, and 10. 7, 9, and 10 has this 4-part construction where we have a motor component, we have a parasympathetic component, a visceral sensory, which is generally taste, and somatic sensory, which is touch and pain and so forth. Okay? So it's organized kind of in parallel. You just have to be able to differentiate between these 3 signals. Okay, 2 more, okay? The accessory nerve. Okay, this is a simple motor nerve. Its function is the sternomastoid muscle as well as the upper trapezius muscles, okay? We start with the spinal accessory nucleus, and the sternomastoid is a muscle along the front side of your neck, this way, and its job is to kind of pull your head in the opposite direction, okay? So the left sternomastoid would turn my head to the right. So it doesn't really push it, but there's a way that it contracts and pulls it in the opposite direction, okay?
Also called sternocleidomastoid.
Sternocleidomastoid, yep, same thing, just less writing, okay? Okay, and then it also does the upper trapezius, which elevates your shoulders. Okay, and moves head in the opposite direction. So very easy to test this cranial nerve. Doctor will put their hand on your face and say, push against my hand to see if you have strength. And then they'll say, shrug your shoulders. What they're looking for is if the shoulders are elevating in symmetry, so they look the same. And then they'll put their hand on your shoulders if you can push against the weight of their hand to kind of test for strength. Very simple, okay? Questions? Okay, 12, hypoglossal. Glossal meaning tongue. So this is the intrinsic as well as the extrinsic muscles of the tongue. So it begins with the hypoglossal nucleus, and it will go to any number of these: genioglottal, hypoglossal, styloglossal. So if you know your tongue muscles, it goes to all of them, okay? Damage, we'll just finish this out, tongue muscles. Damage leaves weakness in tongue. Your tongue is actually divided. The right side of your tongue is controlled by the right hypoglossal, and the left by the left hypoglossal. So if you damage one of the hypoglossal, it's very simple to ask the individual to just stick out their tongue, right? You need both sets of muscles. When one muscle is not or weaker than the other, the tongue will deviate towards the weak side because it's not able to oppose or create enough force. The other side is more strong and it overwhelms and makes the tongue curl. Okay? The other way is you can use a tongue depressor and say push against the tongue this way, push against the tongue this way, but the easiest is just ask them to stick their tongue out. Okay? Okay. The upper motor neurons that control the hypoglossal nucleus are coming from the opposite side. So we have that normal contralateral control. Where it crosses is kind of unknown anywhere, somewhere between the cortex and the hypoglossal nucleus, but they'll cross over. So the right face, tongue part of my homunculus is controlling my left hypoglossal nucleus, controlling my left side of my tongue, okay? All right, we did it. We did all 12 cranial nerves. I have one more topic to share with you, and then I can free you. Any questions so far? Yes, Mike.
So damage to your right hypoglossal, your tongue goes to the right?
Yep. So the lower motor neuron, the hypoglossal nucleus, to my tongue muscle, they're going to be ipsilateral. But the upper motor neuron, where my tongue control from my homunculus, in this case will be opposite. So it's not bilaterally innervated like some of our other cranial nerves. This one is just the typical contralateral cortex to the lower motor neuron. Yeah. So all cranial nerves are ipsilateral to where they're going. They pop out, the right trigeminal is on the right, it's going to the right side of my face. At that point, there's no crossing. The crossing happens earlier if it's going to cross. JD.
How would you distinguish between upper motor neuron and...
Oh, very good question. That's a $64 million question in our class. How do you think we would distinguish between a homunculus lesion on our cortex right at our tongue versus hypoglossal? Who wants to offer?
There'd be a lot more symptoms if it was.
Yeah.
in the brain.
We should see some facial paralysis, right? Because the tongue is right in that facial. So it's really possible, but improbable that we just get the tongue on the cortex. So if anything else is, we should see some, smile asymmetry, or you can ask them to puff out their cheeks, and one side does not. Then we know it's cortical. But if everything else is just but the tongue, then we're thinking hypoglossal. Okay? Yes, Aya.
So, you were saying the hypoglossal is contralateral control?
From the cortex. Okay, so I'll use this white screen. You have two sides of your cortex, so you have a tongue muscle controlling center on your primary motor cortex. It controls the hypoglossal nuclei here, which then controls this side of the tongue. Okay, so it is, the original information is starting off on the contralateral side of the brain. The nucleus is on the contralateral side to the ipsilateral part of the tongue. Make sense? Okay. Any other questions? I have one more topic to give you. All right, so there is something called cortical bulbar that should fit well right here. The cortical bulbar tract is a fiber tract, which is not very, it's not an obvious white matter tract. But bulbar is an old term for medulla. So it's cortical medulla connection. And more specifically, it is cortical medulla connection specifically of the motor neurons of cranial nerve, or the motor components of cranial nerves. Okay? So not all cranial nerves, just the motor component, or the motor side of them. They're one of those mix. Now, these cortical bulbar tracts will innervate those motor neurons, like the nucleus ambiguus, and the facial motor nucleus, et cetera, et cetera. So it's a separate tract that comes in and creates an added bit of influence. And they contribute to modulating those motor neurons, so that seems fine. The reason I bring this up, because there's an interesting pathology to the cortical bulbar tract, and that is called pseudobulbar affect. Okay? Now, pseudobulbar affect involves all the motor components of these cranial nerves. And when do we use them? We use them for things like crying and laughing. When you cry and you laugh, you squinch up your face, you use your vocal cords, you're heaving your palate up and down. So you can see all our cranial nerves here, right? The lacrimal glands are going, the snot is going at full force, the saliva, you little kids who are crying, they're just drooling all. Every bit of parasympathetic, you can see it happening in a child that's just had a meltdown, okay? But in pseudobulbar affect, we get all the motor side of that laughing and crying without any emotion. So the emotion starts up in the cortex. You have to feel sad, you have to feel mad, you have to feel funny, you have to feel like it's hilarious, you have to understand, and then you tell your brainstem, emit the motor patterns that will lead me to creating a laugh or creating a sobbing sound, right? Or all the other parts of crying, the tears and the saliva. So pseudobulbar affect is just the latter half without the motivation for it. So individuals with pseudobulbar affect will spontaneously burst out in crying or laughing for no good reason. They get themselves in a lot of trouble. Like a lot of my case studies are, I took my boyfriend to my grandfather's funeral and he would just laugh and laugh and just wouldn't stop. And so that was the end of my, that's how the case studies like to kind of exploit this inappropriate presentation, crying out of nowhere, okay? So, let's see, there were some criteria that I wanted to make. Oh, yeah, here we go. So, 3 common features are, 1, they have to be involuntary. Okay, meaning, you know, you don't really want to cry and laugh, but all of a sudden it happens. It's embarrassing. My girlfriend's gonna break up with me, etc. Their motivation's not to do it. 2, it's very brief. Okay, this is not a long jag of crying. This is, you know, 5 seconds and it's over. But it's just such a sudden outburst. It's bizarre. Okay, and then 3, it's very stereotyped. Stereotype meaning it's a type of behavior that we see amongst many pseudobulbar, so it can't be really just unique to you, that you decide to laugh and jump on one foot, then there's something else going on with you, right? So this has to be a more common, using all the cranial nerve motor outputs, okay? So I just wanted to pull that up. This pseudobulbar affect can be by itself because you had a stroke or some damage to that pathway, or it can be one symptom component to a larger disease like ALS, Alzheimer's, where you have degeneration, and so then the cortical bulbar tract becomes part of that degeneration. It becomes one of the different things that are degenerating, okay? Okay. I have a very simple case. Yes, Felix?
The pseudobulbar effect, is that basically like Tourette's?
No, Tourette's comes from the basal ganglia and the subthalamic nucleus, so different, but
The involuntary, yeah.
it's involuntary, but it's a very different mechanism.
Okay.
Yeah. Okay, anyone else? Yep,
Is
Emily?
it only during like opposite situations?
No,
or
it could just,
always?
you know, people, if you look on YouTube, it's very hard to know if they're real videos or someone pretending, but they're, you know, someone's filming themselves in the car. It's like he's not getting out of the car to go into the store until this seizure of sort of behavior ends. So he's sitting in his car laughing, and then he would laugh again and just sat there until it kind of subsided. So I don't think it's specific, but when you make a case study, it hits a more humorous tone when you bring in the opposite social situation that's necessary. Anybody else? Okay. Real quick case, it's really hard to find a cranial nerve case that doesn't involve a bunch of other brain areas. So a 51-year-old woman saw an ophthalmologist because she noticed her left eye seemed to be bulging out further than her right. That's very disconcerting. For the last 3 to 4 years, so what was she doing in years 1 and 2 and 3? But anyway, I would have gone right away, and she had recently developed some headaches. Lady, I would have gone so much earlier. Exam was normal, except she had the bulging of her left eye. This is called protosis. Right? Ptosis, you know that term, protosis. And decreased sensation to touch and pinprick over her left cheek. Okay, so we have another second. Anybody want to hazard a guess or at least identify the most important aspects of this case? Just to start practicing. What's really salient? JD, is that, no, that's not a hint. Okay, yeah. Felix?
A lot of the sensation or, yeah, like it's on the left side, so maybe something on the right brain, or towards the right brainstem.
Okay, pick one, right brain or right brainstem, because one is maybe and one is very wrong.
Yes. Okay.
Okay.
Well, we're talking about cranial nerves, so.
So if you're talking about cranial nerves, then it has to be left brainstem, because they don't cross. Okay, but you're right to think right cortex would get to my left brainstem, right? So which one? Do you think it's starting from the cortex, or do you think we're starting at the level of cranial nerve? Liz, I see your head shaking.
I think it's at the level of the cranial nerve.
Yep. So which cranial nerve would be most indicative of, we don't have one for bulging eyes, don't even try. That's not a cranial nerve. But what about the diminishing sensation across your cheek? Trigeminal. That's the only one we can pin right now. So the problem with this is that's the end of the cast. The picture here shows a tumor growing in the back of her eye, which is what's causing the eye to bulge out. But the tumor, what you don't see, is it's pressing on a branch of the trigeminal nerve. So that's where this comes along. Okay. So the eye, the protosis, not involved, but certainly we can explain it because of the trigeminals passing by. Yes? Owen?
Is that actually her eye?
This is her eye.
What, is that not obvious?
What do you mean?
Should she just look in the mirror and be like, oh, it's just another one day?
Yeah, I know. You gotta wonder. People are really hesitant about going to their doctor. I mean, I took a biology of cancer class when I was your age. I was a senior. I'd done all my stuff, so I'm like, why not biology of cancer? There was a picture of someone with a tumor at his genitals, but it was like this big. And so we were wondering, like, where were you, what were you thinking when it was this big? And why didn't you think about thinking of looking at it when it was this big? But while we're here now, people are really hesitant to go and have someone tell them bad news, so they would rather ignore it. So that is a lot of psychology in being, thrown into the healthcare world. And if you guys are savvy to it because you're learning all about it, it doesn't frighten you. But if you don't know the lingo, right, it's an entirely scary landscape. And so you see this kind of thing a lot. All right, so this literally, I think, is my left. Oh, this is not to be tested on, but just to remind you, the cranial nerves have their origins, their nuclei, and their origins are beyond where the nerve pops out. So here, you know the trigeminal is coming out of the pons right here. It's big, but it just comes out about the midpoint of this pons. But the trigeminal nucleus runs the whole length. So you may come across, I try to avoid them, but you may come across a case where you see trigeminal symptoms, but you're nowhere near this cranial nerve. And you just have to allow, we probably are picking up some of this nuclei. That's why we see it, okay? So always keep that in mind. That's my only caveat for not teaching you the nucleus positions, which you will learn in medical school, PA school. You'll get that. So it is important, but it does belabor this cranial nerve anxiety we have in here. Okay? Any questions? I made it in less than 2 hours. We have 5 minutes to spare. Any questions? Any last minutes? I really appreciate you sticking this out with me. Friday and Monday, you're going to come back here for class, and the TAs will bring out, we're going to really work on the atlas I put on your D2L, has no labels on it, so have access to that somehow. They will answer your questions. There are labs, so you should work through the labs. The first one is a cranial nerve lab. There are questions in the cranial nerve lab that you should try to answer. TAs will give you the answers ultimately. And then on the next lab, next week's, is cerebellum. And they will bring the brains out then, okay? All right. Thank you again very much. Have a great week.